Hello, I'm Dr. Chikadlu Debuna. I'm here to discuss abortion counseling for the NAC OSCE preparation. It's important to note that abortion is a sensitive topic, and hence the doctor should assume a non-judgmental stance when discussing with the patient. So for our NAC station, we have Mary Lawrence, a 20-year-old, who is here to talk about a concern. Please talk to her in the next 11 minutes. So what is expected of the doctor? Since the station stated 11 minutes, we should know that it's a counseling station. And the aim of a counseling station is to test the doctor's communication skills. So in order to achieve this, we have to allot a good amount of time for the counseling proper, while taking a concise history. This is to enable the doctor have ample time to discuss with the patient and address all the possible concerns. So for the history taking, after the introductions, we find out from the patient what brought the patient to the clinic. The patient will state that she is here for an abortion. So the doctor will have to find out how the patient got to know about the pregnancy. When was the patient's last menstrual period? Has the patient experienced any symptom since the pregnancy? Other important questions like the patient's blood group, the patient's resource status, if the patient is aware. And it's important to find out how the patient feels about the pregnancy. Is the patient's partner supportive? Having this in mind, we have to bring the social history up and not leave it till the tail end. So we have to find out if the patient's partner is aware of this pregnancy. Is the patient's partner supportive? Was this pregnancy achieved through an abuse or rape? Has the patient informed the family members? Are they supportive? What about her friends? We ask questions about her education too. Other social history like smoking, alcohol, and illicit drug use, because we know this can negatively impact pregnancy. So after taking the social history, we have to go to the gynecological history. We find out if the patient has any ongoing gynecological condition or if she has had any in the past. It's very important to get the contraception history, because it's either the patient was not using contraception or that she had a failed contraception that led to this pregnancy. Also, for her obstetrics history, we find out if this is her first pregnancy or if she has had any in the past. Then other important aspects of the history. Then for the counseling proper, like I earlier said, abortion is a sensitive topic, and this must not have been an easy decision for this patient. So we have to show a lot of empathy when discussing with the patient. We have to read the patient's body language and know when to empathize with this patient. So we have to find out this patient's thoughts concerning abortion. If we believe she has any misguided thoughts, we can correct it. We also have to screen this patient for depression, because we know that some people who decide to go through abortion, some of them are plagued by guilt that can lead to depression. So we have to ask the important questions concerning her mood and her interests and other aspects of depression screening. Then we have to let the patient know that we acknowledge that it's not easy for her to come to the clinic to discuss this, and that we are going to do our best to support her. Then before we begin counseling her, we'll find out what she knows about abortion. because depending on her knowledge about abortion, it will guide us on how much more information we can give her. So for the abortion itself, we will educate her on it and let her know the various methods, and that the various methods, which could be medical or surgical, will depend on her gestational age. So for those that are less than 9 weeks, the medical means is commonly used. The medications include mifepristone and misoprostol, and they have the side effects of bleeding and pain. And for the surgical means, it's usually done for those 9 to 14 weeks and 14 weeks and above, depending on the type. We'll also discuss pain control. We'll let the patient know that we'll give her pain control to control her, to alleviate her anxiety. Then while counseling her, we'll let her know that there is no legal gestational age for which abortion cannot be performed. It's usually at the discretion of the physician. We know if the patient decides to go on with abortion, even if the physician is unable to, does not believe in abortion, the physician is bound by duty to refer the patient to the right source. So we have to tell the patient the complications of the procedures, either medical means or surgical means. It's true that Mary came to the clinic with abortion in mind, but we'll still have to give her other possible alternatives. We can let her know that in addition to abortion, she can actually decide to carry the pregnancy to term and deliver and give up the child for adoption. So we can talk to her about the available adoption services. We can also let her know that she doesn't have to make a hasty decision, that she can rethink about keeping the baby, and that there are social workers that can come to play and help if she decides to keep the baby. So for this, we can give her, say, about 3 days appointment to think about it and come back after 3 days to discuss her decision. Then we cannot let Mary go without discussing contraception and family planning methods. So we are going to discuss this with her in view that she does not encounter